Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. In the last session on GDMT, that is the Guideline Directed Medical Therapy, we have discussed that when patient has got features of fluid overload, you give diuretics and optimize volume and then go for the GDMT, the 4 pillars of therapy. One drug from each of the class should be given, and the newer guideline says we can start all the drugs simultaneously and gradually titrate upwards. And many times, practically, sequential therapy, that is, one drug followed by the other, is added in a tailored manner depending upon the patient's status. Anyway, the drugs which are used, one drug from each of the classes. So first we take the RNA or RAS blockers. RNA is preferred over ACE bar ARB. The common drug is the sacubitril valsartan. You start with 24 bar 26 milligram, that is 50 milligram tablet. Every 2 to 4 weeks, you increase the dose in such a way that you can achieve the target is 97 by 103, that is 200 milligram tablet twice daily. So the dosage starting is 50 milligram, that is 24 bar 26 twice daily, step up every 2 to 4 weeks, such a way that you reach the target of 97 by 103, that is 200 milligram twice daily. If the patient has got contraindications like angioedema, or the patient cannot tolerate due to financial reasons, etc., you may go for ACE or ARB. If it is ACE inhibitor is used, it is enalapril 2.5 milligram twice daily, step up to 10 to 20 milligram twice daily. Again, it is done over 1 to 2 weeks. So start with 2.5 milligram twice daily, increase every 1 to 2 weeks so that the target is achieved. Many patients will not be able to achieve the target. If the patient can't take ACE inhibitor, you may go for ARB like losartan 25 milligram daily, step up to 150 milligrams daily. Every 1 to 2 weeks, the dose is stepped up so that you reach 150 milligram target. The second drug is beta blocker. The usual drugs are, one is bisoprolol. You can use carvedilol or metoprolol succinate. Bisoprolol is given 1.25 milligrams daily, step up to 10 milligram. Again, it is done over 1 to 2 weeks. If it is carvedilol 3.125 milligram twice daily, step up to 25 to 50 milligram twice daily. The beta blocker should be gradually only stepped up, that is every 2 to 4 weeks the dose is stepped up. Then comes the mineralocorticoid receptor antagonist. The routinely used one is the spironolactone. Here you use a small dose, 12.5 milligrams q daily, increase to 25 to 50 milligrams, again 2 to 4 weeks. The SGLT2 inhibitor, the DAPA and empagliflozin doses, there is no need of titration, only a single dose 10 milligram is given. And again, as mentioned, the diuretics are to be given for symptomatic treatment. Usual given is the furosemide 20 to 40 milligram. It can be stepped up if required. So the dosage should be adjusted depending upon the volume status. And the adverse reactions are common, and you should adjust the dosage and titrate the drugs depending upon the adverse reaction. If the patient has hypertension, reduce ACE or ARNI dose first before adjusting beta blockers. Hyperkalemia, it is usually the mineralocorticoid receptor antagonist. You can avoid the high dosage. ACE inhibitors can also produce. You can use potassium binders. Worsening of renal function, titrate diuretics carefully. Adjust the ARNI and ACE. Bradycardia, reduce the dose of beta blocker and conserve ivabradine if heart rate is more than 70 beats per minute with adequate beta blockade, or if the patient cannot tolerate the beta blocker to the target dose. So the additional considerations required are ivabradine if the heart rate is more than 70 despite adequate beta blockade. Hydralazine plus nitrate can be given for black rice or those intolerant to ARNI, RB, ARB or ACE inhibitor. So hydralazine plus nitrates are given when the patient cannot tolerate the RAS blockers. As mentioned last time, digoxin can be given for symptom relief in selected cases, especially when patient has got atrial fibrillation with the fast ventricular response. How will you monitor the patient? Every 1 to 2 weeks during titration, check the blood pressure, heart rate, renal function, electrolytes, especially sodium and potassium. Once it is stabilized, every 3 to 6 months, patient will be examined. Here you can repeat the BNP echocardiography every 6 to 12 months. Assess the adherence to lifestyle. And the long-term therapy and prognosis, GDMT should be the guideline directed medical therapy should be continued indefinitely. Stopping while improvement is to be avoided. And with this treatment, the patient is not improving and the patient has got advanced heart failure, NYHA class 3 or 4, consider other modalities of treatment like ICD, ventricular assist device to CRT, and even transplant.